Okay, good morning, good afternoon, and good evening. Greetings, ladies and gentlemen. Welcome to the APIU Pandemic Crisis Management webinar series. I'm Zijie Zhang from Peking University School of Public Health. Today's webinar is the third in the series and organized by Peking University in collaboration with the APIU and the National University of Singapore, University of California, Los Angeles, and the University of Sydney. This month marks the anniversary of the start of what has become the COVID-19 global pandemic. The world is still struggling in containing the spread of disease with ongoing surges of infection in many countries, including the newly discovered more contagious variants. As for today, over 90 million confirmed cases and nearly 2 million deaths has been reported globally. So one of the most inspiring news nowadays after this very depressing last 12 years of development, emergency use, authorization of COVID-19 vaccines. Of course, there's more work need to be done really to have this pandemic really under control. So for this webinar, we are very pleased to have 4 distinguished speakers from 4 universities will review and analyze progresses of and challenge facing in the development and application of COVID-19 vaccines, and how we can quickly roll out the vaccination program to help contain the pandemic. Before I introduce our speaker, I would like to invite Dr. Chris Chemawat, Secretary General of APIU, and Professor Maninzo, Deputy Director, Office of International Collaboration at the Peking University, to give welcoming remarks. So let's go with Dr. Chemawat, please.
Thank you so much, Professor Chung, and welcome and good morning, and the rest of the timings to those of you on this webinar. It's a great privilege to welcome you and to this webinar hosted and led by Peking University School of Public Health. As Professor Chung has mentioned, this is the third webinar in a series of 4, which kicked off last September with the first exploring the experiences and lessons learned in responding initially to COVID-19 in China, Australia, US, and Singapore. And then the second webinar focused on insights and case studies of a partnership between academia and government and public policy. So as has been mentioned, we're now at a critical juncture, a year into the pandemic. More efforts are needed from governments, international organizations, the private sector, research institutions, and others to support and develop new technologies and products. The potential success of the distribution and application of vaccines and other technologies, we've become to realize how complex that exercise is of protecting entire populations. And so today, the webinar will have leading experts from the 4 universities mentioned on to focus on the potential solutions to this complexity of pandemic control. And the progress we're making and the challenges facing us now. So APIU, as you can see on the slide, just to let you know a little bit about it, we've supported the development of the APIU Global Health Crisis Management Program from the beginning because of the impact, of course, on our members around the Pacific Rim. And you can see there, we're a network of 56 research universities from East Asia, Southeast Asia, Australasia, and the Americas. And we're very privileged to have such a distinguished membership with such capabilities, especially in the area of public health. So we've done a number of things in response to the COVID-19 crisis, and we've just put some broad headings there in the slide. Obviously, we have this series on crisis management, but we have more than 10 COVID-focused webinars. We've converted various annual events and to virtual conferences on global health, sustainable cities and landscapes, and so on, and many other programs. So we are very pleased that this program, initiated by Peking University School of Public Health, has become a very strong element of our activities, bringing the research resources of our network and the public policy capabilities to a broader audience. So we hope that these series of webinars and other things we're doing will draw lessons that we can all learn for future public health crises, how to prepare and manage them, and in particular, the role of the higher education sector in doing so. And you can explore all these initiatives we've done on the last panel there, apiuplus.org, if you're interested to look further. So it's my pleasure, finally, to thank again Professor Meng, Dean of the School of Public Health at Peking University, Professor Chung, Chair Professor and Head of the Department of Global Health, who has spoken to you at the beginning, Professor Chui, Director of Vaccine Research Center, and Dr. Wu from the Research and Foreign Affairs Office of the School of Public Health, all at Peking University. Thanks to them for bringing this webinar together. And I also wish to thank my good friend, Professor Manli Cho, who will speak next, who's Deputy Director of the Office of International Relations at Peking University, and all those contributing today as expert speakers. Thank you, and I'm sure you'll have a wonderful and a very valuable webinar. All the best.
Thank you, Chris. I really appreciate your leadership in making this webinar series possible. So now let's welcome Dr. Zhou from Peking University Office of International Collaboration.
Thank you, Zheng Laoshi, and also thanks for Chris for their nice words. Dear colleagues, it is my great pleasure to join today for the third APRU Public Health Crisis Management webinar at the start of a new year. Therefore, I'd like to extend my warm greetings first and best regards, wish you all a healthy and fruitful year of 2021. For the past year, we know the world has been overshadowed by a health crisis unseen in a century, demanding international cooperation like never before. Under such context, APRU provides a valuable platform for institutions of higher education to put resources and wisdom in the development of a broader public health research and education. Today, as we welcome the third cooperative endeavor of the association, I'd like to express my sincere appreciation for APRU's indispensable role, as well as in providing technical support, without which this webinar would not have been possible. The previous two webinars, spearheaded by our two partner universities, UCLA and NUS, have laid a solid and inspiring foundation for our cooperation. Your dedication not only sheds light on the overall COVID-19 research and education, but also generates substantial results from which the human society would stand to benefit. With deep appreciation and carrying the front torch, this webinar under the theme Solutions for COVID-19 Pandemic Control, Vaccines and Beyond continues to work out potential solutions for the uphill battle of global epidemic control and prevention. Today, the sequence of webinars, including the upcoming one organized by the University of Sydney in March this year, construct a crucial dialogue of the theme in discussion. Dear colleagues, the future is ours to share. More still, it is ours to shape. Thank you for your long-standing support in our joint effort in public health crisis management. In the years ahead, the task force will grow into a multiple-dimensional platform for partner universities, forming a comprehensive network of forums and activities around the core team. I believe that under the framework of the APRU, our cooperation will no doubt contribute to a safer and healthier world. Once again, at this meaningful occasion, Happy New Year to everyone, and wish the webinar a complete success. Thank you. Thank you, 郑老师。
Thank you, Dr. Zhou, for your wonderful word and your support in leading this seminar series. So, excuse me, let me make sure that my video is on. So in the next 80 minutes, we have 4 distinguished speakers who will talk in the various topics that covers today's topic. So I'm very pleased and delighted to introduce our first speaker, Dr. Hannah Clapham from Sohi Hock School of Public Health, National University of Singapore. Dr. Hannah Clapham is an assistant professor at NSU School of Public Health and was previously head of a mathematical modeling group at the Oxford University Clinical Research Unit, University of Oxford. He has a particular interest in vector-borne disease such as dengue and vaccine-preventable disease. For COVID-19, Dr. Clapham has been working on modeling the spread nationally and globally, as well as modeling the optimal use of control measures, including vaccination. The title of her talk is Global Vaccination Strategy, Similarity, Differences, and then Lessons. Please welcome Dr. Hannah Clapham.
Hi, everybody. Thank you very much for that great introduction. It's always strange to hear about yourself. All right, let me just get myself started. Okay, hopefully you can fully see my screen now. So welcome, everybody. I'm very excited to be here to talk to you today and to be part of this webinar with, I think, some really interesting speakers from who are going to talk about lots of different aspects to vaccination strategies. Before I start, thank you to the organizers and PKU and APRU for their hard work in organizing and bringing us all together today. So I'm going to talk about global vaccination strategies, similarities, differences, and lessons. So as you heard, I'm a mathematical modeler, and this sort of shapes the way that I approach questions in the way of thinking about things, but it's also been very interesting, particularly with COVID, I think, over the last year, to really think about how modeling sits within the sort of ecosystem of public health and what modeling can do and what it can't do, and how similarities and differences in approaches across countries have manifested, and how modeling can fit in with that, particularly now for vaccination strategies. So I'm going to talk a little bit briefly just about some of the vaccine impact modeling we've been doing in Singapore, and then how that sort of led on to us thinking about what can we learn from vaccination strategies in different places, and what is going to be different about strategies in different places, and why. And I think some of these were sort of fairly obvious before we started vaccination in multiple countries, but I think there's also been quite a lot that's been coming out throughout the vaccination process as vaccines come onto the market that will be very interesting to discuss and think about, and think about how they'll shape the future response. So in general, when we're thinking about a vaccination program, I've been trying to sort of think about this as a link of all these different things together. And I'm hoping that different people in the audience will have other things that they think are missing from this slide, and that it would be great to hear from people later about how we can add to this and other ways that we should be thinking about this. But ultimately, when we're thinking about a vaccination program, there's going to be an aim of that vaccination program. And I think we can kind of miss that bit and think that it's kind of obvious. But actually, there's quite a lot of different aims to a vaccination program. Do we want to reduce the numbers of infections? Do we want to reduce the numbers of severe diseases, severe cases, deaths in certain age groups? Do we want to lift certain MPIs in the economy? And it's not to say that a vaccine program will have one aim, but there's going to be differences, and there's a range of aims that could be there, and they're going to shape who gets vaccinated and what that looks like. Now, of course, that aim doesn't sit in isolation. It's going to be decided depending on a lot of different things that are also going to be part of the vaccination program. So there's, among all these things, a lot of interdependence. So of course, we're talking about vaccination, and we're in an absolutely privileged position globally that we have a number of vaccinations that are starting to be used. We know quite a lot about those vaccines, but of course, there's still some things that we don't know. And this is something that has to be considered within a vaccination program. And then, of course, we have the availability of those vaccines. So this is something that I think most of us today might be in countries where we're privileged that we don't have to think too hard about that, but there certainly are places where that's going to be a long-term impact. And even in places that have optimal supply, that's going to be staggered over time. The bit that I sort of spend a lot of time thinking about within this is the transmission dynamics of SARS-CoV-2. And of course, some of that is specifically biological, general things that we've learned over the last year about asymptomatic transmission, symptomatic transmission. But then some of that is very setting specific. And that's an important part that we spend our time thinking about in modeling and trying to understand what are the specifics of transmission within different settings. Then, of course, we have the other control policies. So I think we've had a bit of an example of where people thought coming into this, perhaps, oh, the vaccination is gonna come in and then everything will be lifted in the population. And I think slowly, of course, we've started to realize that that's not going to be the case. And so we have to think about within the vaccination program, what control policies can be lifted, and sort of going back to that aim a little bit, what do stakeholders want to be lifted within that setting? We then, of course, have the healthcare system and the testing capabilities. And this is something that, again, varies quite a lot between different countries. And I think when we expand this to vaccination, we have to think about what vaccination looks like within this healthcare system as well. What are the capabilities? Then we think a lot about the economics of this, of course. With COVID, we have seen an infectious disease that has affected everything in the population, and the economics of that is a really important part. And then ethics and public perception, perhaps not to be grouped together, and I think we're going to hear a lot more about some of this later, but it is all a really important part of the kind of vaccination program. So, as I said, I spent a lot of time initially thinking about the transmission dynamics, and we were thinking about modeling this for Singapore. So we focus on the vaccination impact on transmission in Singapore, and then what that does subsequently to cases, or what it looks like within that system there. One thing that when we were putting together this model, we have to think about what are the specifics in Singapore. So all the other NPIs that are currently in place, a very, very effective measure of NPIs that are in place currently in Singapore. We have the dorms and the not dorms transmission, the two quite different transmission settings in Singapore. We have to put that within the Singapore healthcare parameters. And then within Singapore, we have to think quite a lot about importations, because that's something that's a large part of the dynamics that could be occurring. And then what we can do within that setting is we can put in the different numbers of vaccines and their actions and being given to different groups over time, and look at the impact that will have on transmission and all these other NPIs and what can be lifted and those kind of things. So I'm not going to talk too much in detail about the results today, but I am going to focus on what we ended up, the process that we went through in thinking about this in Singapore, and how that can be applied or thought about in different places. So after the first vaccinations, what we're going to be doing is using modeling to look at the patterns of the different vaccination strategies, and also testing for continued control. And given the vaccination and the strategies that are going to be in place, what are the NPIs that can be lifted? What are the optimal testings strategies? Now, as I said initially, we of course are putting in vaccines that as we have to continually say, we know these are safe. They've gone through an excellent testing regime, but there are still some unknowns in those vaccines. What the impact on infectivity of people who have been vaccinated, and of course the length of immunity. And so within the vaccination program, we can start to think about what can we say about these, and what are the optimal sort of surveillance strategies that we need to have in place in order to understand that, and what can we do particularly within different settings for looking at that. So I think when we're starting to put together these models, as I said, we put together this model for Singapore, and we feel that it's Singapore specific. There's also quite a lot of work going on globally that's kind of a bit more general. So thinking about more generally, what are the vaccination strategies for a sort of ideal or example populations. And I've been spending quite a lot of time thinking about what can be transposed from one country to another. And I think this is a really important question, because I'm very focused, and sort of something I've spent a lot of time thinking about, on making sure that we have country-specific work and that it's very focused. But is that always necessary? Do we need that? In what places do we maybe that might not be possible? And what can we think about learning from other places? And I think there's sort of some things to think about that we think about within modelling specifically, which is what is the current state of the epidemic? You know, are we in a time of high transmission, like in some countries like the UK where I'm from, or are we in a time of very low controlled transmission like Singapore where I'm sitting right now? What are the demographics of the population? And of course, the numbers of vaccines and the different vaccines are going to be different in different places. But of course, there are other characteristics that are different between places or similar that are not directly going to be included in the model or within the biology that we're thinking about in the model. But there are going to be some very important things that mean that actually some of these models might just not be that useful for different places, or will have to be tweaked quite considerably to look at that. And so going back to this figure, what can we let me go back. What can we learn from what's going on in other places? And so first, what we've seen is an interesting difference globally in the different decisions about who to vaccinate first. And I think this has been really interesting in seeing what's happening. Some of the strategies for example, in Indonesia, where they're targeting working age population. Other countries are sort of starting with healthcare workers or people who are at more risk of severe disease. You know, those kind of questions will all be being made on the country with different factors factoring into that decision. So of course, that's something that is going to be different from different places. Now, I mentioned about the unknowns about the vaccine that's going into the population. So when we're thinking about vaccination, we hope that we'll be able to learn about vaccine efficacy from places that have these programs started and ongoing, and perhaps we'll be able to learn about the impact of vaccinating certain groups. But that's something that we will have to think about a little bit more carefully, because it's all going to be happening in the setting that vaccination is happening, and we have to think very carefully about how applicable that will be to other places and other settings. When we're thinking about this in Singapore at the moment, we have fairly low transmission, and kind of thinking that will probably continue. You know, these are the kind of some of these vaccine efficacy things we can be measuring about immunity, but some of them about the impact on transmission, and others will probably not be done here, but will be from other places. So I'm not going to go through all of these, but I think I'm just going to talk a little bit more about the transmission dynamics. So again, hopefully from other places, we'll be able to learn a little bit more about the biology and the transmission as vaccines are rolled out. And I think also we're seeing, and this is not my area of expertise, but something that I think does end up feeding back into the modeling and the efficacy of the vaccine program is about the distribution of the vaccines. And we have some specific issues, or perhaps not issues, but things that need to be taken into account, particularly with this vaccine, such as the cold chain and the need to be used in a certain time, that we're seeing really do need to be factored into having the impact that we would be projecting on transmission in different places. So I think there's hopefully, you know, as we're a audience here from lots of different places, we can really start to think about what we can learn from other places, and what our setting and the work that we're doing in our setting can be, how that can help inform policies and decisions in other settings. And then the other way of thinking about this is what is different about the decisions in different places. So not necessarily what we can learn from other places, but what is different about them and how that's coming forward. And again, I think we have some fairly things that might have been fairly obvious coming into this, but others that I think that have been coming through over time that I've been finding very, very interesting. So of course, starting again with vaccination, we of course have differences in vaccine availability. We've seen that in different places, which vaccines, when they're coming in, huge global disparity in that. But one of the interesting things that's also been coming in has been the interpretation of evidence. So in different places, what evidence is needed to do a vaccination program? We've seen in certain places using vaccines more widely before perhaps phase 3 trials are finished. We've seen certain places that have been using different bits of evidence to change the dosing schedule of vaccinations. And I think that's a very interesting thing that's been happening in different places. And I think it's also sort of feeds into a lot of these other things that are happening here. And I think one of the big things that we're seeing with that is how that is interacting with the current transmission. So that sort of risk benefit that comes from doing different things given the current risk against COVID. And that leads us into the current transmission dynamics. What's the current transmission? And we also have to think within the transmission dynamics of other things, such as who in the population is at high incidence, who's getting infected, but also who's at high risk of severe disease. And though we know generally about some of those are going to be quite setting specific, and different decisions are being made. Within control policies, this is something that I think is going to be important in every place, but very different decisions will be being made, is the desire to lift different controls. Of course, part of this is about what controls are in place currently, but then part of it is about, and it sort of feeds into the economics and the ethics and the public perception, what wants to be lifted in the vaccination program, and how has that impacted the decisions that people have made about what to use. And then I think finally, just briefly, I think this important aspect of vaccine acceptance and uptake. And so I think this is something that we are seeing quite a wide range of globally, and is something that will be feeding into the decisions in different places, and of course the impact of the vaccination program. So I think when I sort of started from a model of like conceptualizing the transmission in one place, and then started to think about how that can be expanded to other places. And I think that as I sort of went through those differences and the similarities in different places, I think there are some things that are similar in across places, and perhaps some of that global modeling where we say, oh, it's better to vaccinate certain groups can be of use. But I do still think that there's enough differences in different places that a real understanding and a targeting of what's important in different countries is going to be really important for these vaccination programs. And the way I'm thinking of it for how we model them and what we're looking at within those. Of course, there are many factors that are important for a vaccination strategy, and we're going to hear a lot about those today. And I'm sure many of you are thinking about many of those different factors and how they all fit together within this sort of ecosystem of vaccination within your own work. And I think as different countries start to take different strategies, it's interesting to kind of think about why and what we can learn about that. And what that sort of could mean post-COVID, and I think there's lots that we can start to think about beyond COVID and what the world looks like post-COVID. But I think, and also it's important to think about what we can learn from different places, and some of that's fairly straightforward in terms of vaccine efficacy and those kind of things. But some of that is a little bit more nuanced in terms of putting what's done in the context of the country, in the context of the transmission that's happening, the control measures that are in place, and other things that are happening there. So I'd be very interested to hear from anyone in the audience who's kind of thinking about this kind of work. It's particularly on the modeling side and how that fits in, and if there's any sort of possible ways we could work together in the future. I think that would be really interesting. Now, I just wanted to leave with this figure. So I think when we're talking about globally, of course, we can think on different countries and what their strategies are and what their decisions are, and that's really important, and what we can learn from other countries. I think we also have to think very carefully globally about who is having access to these vaccines. And I think the green areas are the places that are starting to have vaccines, and then the gray areas are places that currently there are close to no data, but we also think probably very little vaccination going on. And in some places, this is a way up of a difference between the risk of transmission, which is currently perhaps very low, and sort of the risk of vaccination, or the decisions about vaccination that are happy to take a bit slower. But in some places, what we're seeing is a huge global disparity in who has access to vaccines. And I think, as most of us are sitting here in countries where we're able to get the vaccine very, perhaps not very easily, but there is a national possibility to be getting vaccinated. We also do, in my opinion, have a bit of a responsibility to think a bit more globally about this, and to think about what within our own research and what within the way we're thinking about things, we can think more globally about this. And I think, we've seen some people globally tell us that what happens globally makes an impact to everybody. And I think we've very clearly seen that with COVID, right? A disease that started in one country spreads globally, and that's something that, and it spread globally from many different countries to many different countries. Everything is kind of linked. And so when we're thinking about vaccination strategies, I think that's a really important thing to think about as well. And so I sort of urge you all to spend a little bit of time thinking about this, and I would be really interested to hear from people who are sort of doing work to think about how we can get more vaccines and how we can think about vaccinations on this more global level. So thanks very much for listening. It's been my pleasure to talk to you today, and I'm really looking forward to hearing from the other speakers and to the discussion later. Thanks very much.
Well, thank you, Hannah. This is a wonderful talk that really summarized the important factors that relate to vaccination policies and others. Well, just want to remind to our audience that if you have any questions or any comments, please do write in the chat area that so we can discuss some of those comments and discussions and questions later during our discussion session. So please do write your question, your comments at the chat function. All right. So I'm very pleased to introduce our next speaker, Dr. Jess Clark. Dr. Clark is an associate professor in the Department of Medicine, Division of Infectious Disease, and Department of Family Medicine in the David Geffen School of Medicine at the UCLA. His research addresses the integration of new prevention technologies within the social and sexual network of Latin American and Latino MSM population. He's a director of UCLA South American program in HIV prevention research training program. He's also a medical director for UCLA Vine Street Clinic and also a principal investigator for the COVID-VPN COV trial of Moderna vaccine. So please welcome Professor Clark to give talk. And the title of his talk is COVID-19 Vaccine Research in the United States, State of the Science. Jess, please.
Hey, thank you, Dr. Zhang, and thank you to the organizers from APRU and PKU for having me speak. It's a great pleasure. I'm going to speak a little bit about the development of COVID-19 vaccines in the United States. As part of my work as medical director at UCLA Vine Street Clinic, we were one of the sites for development for the clinical trials of the Moderna mRNA vaccine. So I have a little bit of experience in that, and we can speak about, I'm going to speak primarily about that in the Pfizer vaccine that are currently been approved by the US FDA for use. So during this talk, we're going to talk about a few things. First, just where are we? What's the current state of vaccine development and distribution within the US? How did we get here? What was the process through which we identified and evaluated SARS-CoV-2 vaccines for use in the US? And what have been some of the successes and limitations of the clinical trials to date? And then what happens now? A lot of the issues that have come up to date in terms of developing and evaluating vaccines remain issues as we're working on distributing the vaccines and looking for other potential candidates to use in the population. So we'll try to figure out briefly where we go in terms of assessing and introducing new vaccine candidates. So where are we? Probably everybody knows that both the Moderna and Pfizer BioNTech mRNA vaccines have been shown to be highly effective, almost 95% for each of them, in preventing SARS-CoV-2 infection, in both of them highly effective in preventing serious SARS-CoV-2 infection. So among the few cases of infection that occurred, none of them were serious cases in the vaccine arms. We're currently in the US working on distributing the vaccines with prioritization in 4 waves. So first, healthcare workers and residents and staff of nursing homes and long-term care facilities. That's where we're currently introducing the vaccine right now. The next wave, which is starting imminently, is for people who are over the age of 75 and essential workers. Essential workers being people, for instance, shopkeepers, delivery people, people with regular contact with lots of other individuals who provide essential services to the economy. Then the next group will be people over the age of 65, although the Trump administration has just announced that they would like to make the vaccine available to everyone over 65 years as of now, and or people with high-risk medical conditions. And then finally, there will be everybody else in the population. And those people will expect to be vaccinated probably in the summer here, which would be July, August, by the time they get to everyone in the population. There's currently 4 other vaccine candidates in trials with preliminary evidence of effectiveness for AstraZeneca's product. You probably know as well, there were some issues with the AstraZeneca trial from the UK, so that they had 2 different estimates for effectiveness. One was 62% and one was 90%, and they averaged the 2 and came up with, I think, 74% for overall effectiveness of their vaccine. So their trial in the US is currently in process, and so we'll have additional information once that is completed. And then there's other vaccine candidates that are in varying stages of development, either preclinical studies or well advanced in phase 3 trials, which everyone's waiting to see the results and are very exciting as well. So how did we get here? In the US, they created something called Operation Warp Speed, or OWS. In May 2020, Operation Warp Speed was developed to deliver tens of millions of doses of a SARS-CoV-2 vaccine with demonstrated safety and efficacy and approved or authorized by the FDA for use in the US population beginning at the end of 2020, which they were effective in doing, and have as many as 300 million doses of such vaccines available and deployed by mid-2021, which they're trying to do. Last I heard, they were projecting to have about 200 million doses available in the US by the middle of the year. Operation Warp Speed was an unprecedented public-private partnership in that private companies were responsible for developing the product and distributing it, but were aided by the full capacity of the US government to ensure that no technical, logistic, or financial hurdles would hinder vaccine development or deployment. So the US government basically went to companies who were developing the vaccine and offered them carte blanche in terms of support to make sure that they could develop, assess, and ultimately distribute their vaccines if effective. It was based on 4 different platform technologies. One was mRNA, which are both the Pfizer and the Moderna vaccines are based on. 2 is a replication defective live vector or an adenovirus vector in most cases. 3 is a recombinant subunit adjuvant protein vaccine. And then the 4th is an attenuated replicating live vector vaccine or attenuated or virus form. For each of these 4 mechanisms, they want to have at least 2 candidate vaccines to assess. So as I just said, the mRNA vaccines were Pfizer, BioNTech, and Moderna. The replication defective live vector or adenovirus vector was AstraZeneca and Janssen. And then the recombinant subunit adjuvant protein, which are currently in trials, are Novavax and Sanofi GSK. The attenuated replicating live vector, I believe, is being tested by Merck, but that's more information is still pending on that. The other thing that Operation Warp Speed did was to create the COVID-19 Vaccine Prevention Trials Network, or CoVPN. That's the network for which UCLA Vine Street Clinic is one of the sites. What they did was to take the existing HIV research networks in the United States, so the AIDS Clinical Trial Group, which is primarily focused on HIV treatment, the HIV Vaccine Trials Network, and the HIV Prevention Trials Network, and took the existing sites for these networks and the existing infrastructure and redeployed it for the development of COVID-19 vaccine and treatment studies. This provided a ready-made consolidated national framework for rapid implementation of sophisticated clinical trials to address both prevention and treatment of SARS-CoV-2 infection, as well as the epidemiology of infection. So obviously one of the main goals, one of the main objectives of this network was vaccine development through Operation Warp Speed. We've also worked on studies of monoclonal antibodies, for instance, in use of post-exposure prophylaxis, as well as for treatment of COVID-19 infection. And then they're also doing studies of the epidemiology of COVID-19 incidence and transmission within the United States. So we'll talk more detail about the Pfizer, BioNTech, and Moderna vaccines. Pfizer BioNTech was developed independently of the Operation Warp Speed study. They decided to go on their own to use a similar structure where BioNTech developed the product and was essentially the sponsor of the study, while Pfizer was responsible for the clinical trial and for distribution of the vaccine once effective. In their clinical trial, they had 152 sites, 130 of which were in the United States, so mostly US-based, but also sites in Europe, South America, and South Africa. They administered 2 doses of their vaccine, BNT162b2, at 30 microgram doses, 21 days apart. They enrolled 43,548 participants, and in their initial analysis included 37,706. The demographic distribution, 83% of their participants were white, 28% were Hispanic or Latinx, 9% were African American, and 42% were older than 55 years, so considered to be a high-risk group. In the primary outcome of their analysis, they found that there were 162 cases of COVID-19 infection in the placebo arm and 8 cases of infection in the vaccine arm, which occurred more than 7 days after the second injection, giving it the 95% effectiveness or efficacy that was reported in the trial. You can see this in the first row here. With some modifications, there's among people who might have had infection at baseline, similar numbers were found with 9 cases in the vaccine arm and 169 in the placebo arm for a similar effectiveness, 94.6, but essentially it's 95% effective. With the Kaplan-Meier curve here, you can see that the astonishing difference between the vaccine and the placebo arms. And some of my colleagues have said that anybody who has doubts about whether or not they should get this vaccine simply needs to look at this curve and to see the dramatic difference you see here over just a short period of time. You can also see a breakdown of some of the data that they have here, where participants after dose 1, but before dose 2, we're less likely to have infection, even the placebo arm. So you see a certain level of protection even after the first dose is given, even before the second dose has been given, even before the vaccine has had sufficient time to actually show its effect. So you see it's about 52% effectiveness in that first dose period, although yes, the confidence interval does go down to about 30%. So obviously you much prefer to be at this ultimate point where you have 95% effectiveness after full benefit of the vaccine has been found. But again, it's a very reassuring to see that there's at least some protection that's offered in the first week after the first vaccine is given, that you don't need to wait for the full 3-week interval and then 7-day period to see protection from this vaccine. This is a sample of some of the adverse effects that were experienced. With these mRNA vaccines, it's very common to have adverse effects. They're usually things like fever, fatigue, headache, chills, muscle pains, less commonly GI symptoms like vomiting or diarrhea. And a lot of participants in the study ended up using antipyretic medication to manage these symptoms. When the symptoms do occur, they're usually transient, 1, maybe 2 days maximum before they resolve, and they're always manageable, but they are very common. And one or more of these symptoms is pretty much experienced by almost everyone who gets these vaccines, especially after the second dose, which tends to have a much stronger response than the first dose. Speaking for myself, I just had my second dose of the Pfizer vaccine yesterday, and I can tell you I have a very sore arm, but that's about it. No other side effects from the vaccine that I've experienced. So the Moderna vaccine, which is the vaccine that our site was involved in the assessment of, had a similar structure to the Pfizer BioNTech vaccine. People were given 2 doses of the mRNA 1273 vaccine, 28 days apart, instead of the 21 days apart that you saw in the Pfizer study. They were trying to enroll 30,000 participants at clinical trial sites across the US only to determine effectiveness over a 6-month period. The goal was to enroll 25 to 40% of participants over the age of 65 and or from high-risk groups, which include cardiovascular, pulmonary disease, obesity, diabetes, or HIV infection. And they encouraged racial and ethnic diversity, but didn't have a pre-established parameters for representation when the trial was started. They enrolled 30,420 participants. About 25% were over the age of 65 and 16.7% were under the age of 65, but from one of those high-risk categories. 20.5% were Hispanic or Latinx, and 10.2% were African American. On their primary outcome, they similarly found about 95% efficacy, and that 95 cases of COVID-19 infection were found in the placebo arm and 5 cases in the vaccine arm. Their parameter was 14 days after the second injection was given, instead of 7 days after, like you saw in the Pfizer trial. And again, you see these dramatic Kaplan-Meier curves. This is the primary analysis, or the per protocol analysis, where they're only looking at infections which occurred 14 days after the second dose was given. But you can see this incredible divergence of the curves with a high rate of infection in the placebo arm and a much lower rate of infection in the vaccine arm. As I said, there are, I believe, in the first analysis, 12 cases of serious COVID-19 infection that occurred, all of which were in the placebo arm. None of the serious cases were in that mRNA 1273 arm. And this is a similar analysis looking at modified intention to treat, where they said they looked at all cases regardless of when they occurred without specifying the original protocol endpoint. So in this, you see a similar level of effectiveness. And also you see as well, similar to the Pfizer vaccine, that even after the first vaccine, there's some level of protection that you can observe. Not great, not the 95% that you see after the second dose has been given and the full immune response has been allowed to build, but you do at least see some protection after the first dose is given, which is again reassuring. This is a chart of the systemic side effects that are experienced. Again, these are most often things like fever, headache, fatigue, myalgias or arthralgias, and less often GI symptoms. Again, almost everyone experienced some of these symptoms with varying degrees of severity. They were all transient, lasting usually about 1 day. And certainly nothing that should stop people from getting a vaccine. So where do we go from here? There's both scientific and social issues to address. Scientifically, the key issues are how do you produce and distribute approved vaccines, and how do we assess new vaccines given the fact that we have these highly effective vaccines already available? Cold chain is a very important issue. These mRNA vaccines, because of their components, require storage in a freezer at -80 degrees Celsius, and then can be kept in a refrigerator. The Pfizer vaccine for about 4 to 5 days, and the Moderna vaccine for about 30 days, which allows you a lot more leeway in terms of distribution. But still, you have to have this storage capacity for shipping and storage of the vaccine, which is not always available in global settings. Also, scale up of producing an mRNA vaccine is something that's never been tried before. they're having to do it now, and it's there's a steep learning curve in figuring out how to produce mRNA vaccines at scale and get enough vaccine out to the people who need it without making any compromises. So that's a tremendous challenge that people are facing right now. The other big issue is how do you evaluate new vaccine candidates? So there, some of the other vaccines that are in the pipeline may actually be better than the vaccines that we currently have. In fact, given the norms of scientific progress, they probably are better. They may cost less, they may have less intense production or storage requirements, they may have fewer side effects, they may be more effective. But the question is, now that we have vaccines with 95% effectiveness for a potentially fatal disease, how do we enroll and follow participants in trials of experimental vaccines and not give people access to the vaccines that we currently have available? It's going to be very difficult to assess new vaccines when we have these ones that are already highly effective. And then some of the social issues, where do we go from here? We need to make sure that the vaccines are available to all individuals worldwide. Unfortunately, in the US, despite the tremendous efforts and resources that were put into developing and assessing these vaccines, there doesn't seem to have been a similar plan in terms of figuring out how to distribute and allocate the vaccines. So now that we have this great product, everybody's sort of left wondering, okay, how do we get it to people effectively? And right now it's relying on a mishmash of local regulations and state regulations to try to figure out how best to get the vaccines to people in their local communities. And I have to say, it's not going tremendously well so far. Another issue is acceptability of vaccines and mistrust, particularly in the minority communities that were emphasized in these studies, the African American, Latinx communities, where there's a history of mistrust of physicians, of scientific establishment, and of vaccines in general. So these communities, which are also the hardest hit by COVID-19 infection, and are in many ways some of the most important to reach with vaccines, are also the hardest to reach because there's so much resistance to getting what is still perceived as an experimental vaccine that may harm people. Then there's the logistics as well of distributing the vaccine to underserved areas and low-income communities. Again, because of the infrastructural requirements with the freezer storage, as well as the other requirements for storage and distribution, it's much harder to get to these communities. And as somebody pointed out in a meeting I was in last week, you have what is now an extremely valuable product. So you don't want to just store it with a padlock in some room somewhere. You need to have adequate plans in place for making sure the vaccine is kept safe and kept in appropriate conditions, which is another big challenge. And then finally, the last question would be, what's the effective level of population coverage? At what point can we say that we've covered enough people with vaccine immunization in order to have, quote, herd immunity? How much is enough? Obviously, the goal is to vaccinate everyone possible, but that's simply not going to happen. So at what point is enough? So those are the major questions that we're dealing with in the United States right now. Thanks very much again to the organizers for the opportunity to speak, and I'd be happy to answer any questions at the end. Thank you.
Well, thank you very much, Dr. Clark. Well, you have covered a very large ground in 20 minutes. Already, well, we have some questions coming, and I hope that we will discuss some of these questions at the end of this session. All right. So it's my honor pleasure also to introduce our next speaker, the third speaker, Dr. Diego Silva from School of Public Health, University of Sydney. Dr. Silva is a lecturer in bioethics in Sydney Health Ethics, University of Sydney School of Public Health. And his primary research interests include public health ethics, infectious disease ethics, primarily tuberculosis, complexity, system thinking, and ethics, microbial ethics, and so on. And much of his current works around ethics and COVID-19. So today's talk, he will focus on imposing risk, public health ethics, and COVID-19. So let's welcome Dr. Diego Silva.
Thank you very much. Really appreciate the invitation to speak with you today. So I'm actually really happy I'm going up third after Dr. Clark and Dr. Clapham, because I actually think this presentation goes really well with some of the last points that they each made. So right now, just in the last few days, we're seeing a lot of ethical issues come up with regards to the various vaccines that are being circulated. So One is this question of whether we just give one dose or two, or whether we give one dose delayed greater than 21 or 28 days, whether it be the Pfizer or the Moderna vaccine. So that's a live question right now. And why is that? So in places like the United States, as Dr. Clark pointed out, we see that there's issues with the distribution. There's issues where some of the vaccine has actually been thrown out, has been wasted. There has been stories about that as well. And so, can we somehow make more efficient, more effective the vaccine distribution? Would that mean sort of also in part delaying that second dose, going with that lesser efficacy of the vaccine with a single dose, delaying the second dose past 28 days because of these logistic issues. In addition to this, again, another topic that's already come up is this idea of hesitation or vaccine hesitation in certain populations, including certain population of healthcare workers. So we see, I believe vaccine hesitancy has been between 25 and 30% in the United States, in the UK, particularly with people of color, African Americans, Latinx population. And again, there's reasons for this that we'll get into here momentarily. So again, these are just in the last few days, some of the issues that are coming up that aren't necessarily science focused, right? They're obviously to do with science, but they have to do with these social and political, these ethical issues. So what I want to convey today, or the message that I hope to get across today, is that COVID-19 requires us to think very carefully about how public health measures impose risk onto others. So not just the risk of SARS-CoV-2, but the risk of the actual measures themselves, the public health measures, and critically the context in which COVID-19 is occurring, and the context in which the rollout of the COVID-19 vaccines are occurring as well. So I want to talk a little bit about what is ethics. I'll just briefly introduce that. I want to touch on a little bit of some of the contextual issues that we see around COVID-19 and COVID-19 vaccines. Briefly just mention some of the common ethical issues that are being discussed right now in the literature and in the public debate. And then I want to spend a little bit of time arguing that a big issue that is sort of underlying a lot of these ethical issues, a lot of these social issues, is this idea of risk and risk imposition. So what is that? So I'll introduce that very briefly, talk about that a little bit. And then also I want to introduce a heuristic that a colleague of mine, Max Smith, and I have in a paper that is currently under peer review to help policymakers, decision makers think through risk imposition. And then just some concluding thoughts at the end. So when we think about ethics, we're interested in the following sorts of questions or the following sorts of statements, right? We're interested in how we ought to live. What are the rules or principles that should guide our actions? We want to figure out who we should be. And I've emphasized the ought and the should intentionally. So oftentimes disciplines like anthropology or sociology will be interested in ethics, the values of populations and persons in a descriptive sense. They're interested in to see what is the case. In bioethics, in public health ethics, what we're interested in are those prescriptions, what ought to be the case. And critically, what are the arguments, political, ethical arguments that support those ought and should statements. Critically, ethics is different from law and it's different from human rights. So when we think in terms of law, we think in usually something that is enforceable by the state. It is written down. It is associated with things that you can and can't do. It's usually ought to be black and white, right? Things that you can do, things that you should do, so on and so forth. Human rights, very contentious in certain countries, in certain parts of the world. But again, the idea here is that oftentimes we will enshrine certain values through, Universal Declaration of Human Rights, other United Nations instruments that are then ratified by states, which enshrine sort of these basic rights or things that we're owed. So ethics is different insofar as what we're interested in isn't necessarily covered all in law, right? Law only covers so much. Human rights only covers so much, right? What we're interested in is how we ought to live more generally, which goes beyond law and human rights. So why are we interested in ethics? In part because it underpins a lot of law and human rights. So a lot of the values and the arguments that we see enacted in law and human rights come from ethics. So historically, that's the case, but conceptually, that's the case as well. And as I said just a moment ago, a lot of life falls outside the purview of law and human rights. So if that's what ethics is, and we have COVID-19, we have the vaccines for COVID-19, I want to just look at what is some of the things that are going on in the background or in the foreground that we're well aware of, but that sort of situate the reality of COVID-19 and that will help shape or ought to shape our thinking about policy when it comes to COVID-19 and vaccines, and think about ethical policy in the context of COVID-19 and vaccines. As already been mentioned by Dr. Clark, we see that in places like the United States, Canada, Australia, the UK, it is racial minorities or minority, persons of color who are being subject to the ill effects of both infection and disease at higher rates than the general population. We also see that a lot of the anti-vaxxer, a lot of the vaccine hesitation, even amongst healthcare workers, occurs in Black and Latinx populations, for example, in the United States. Why is this the case? Well, we know that in part it has to do with the history of mistreatment of Black and Latinx populations in the United States. So for example, those of us who have done research ethics from a Western tradition, a Western viewpoint, know of Tuskegee, which was a natural experiment of syphilis in Black airmen in the south of the United States. There's been a lot of atrocities done to these populations historically, which has fomented a lot of the mistrust in government, in healthcare workers, or in the healthcare system rather, more broadly. And some of these reasons are still around now, right? I'm touching that in a second. We know that income inequality is an issue, and income inequality has been growing steadily since the 1980s at a global level. Certainly in high income countries, this is an issue. The Gini coefficient, which is an index measure of inequality, is increasing in terms, we can measure that inequality between individuals within a country and between countries is growing. For example, we know that billionaires have seen their fortunes rise exponentially. So this, one article from the BBC says 27%, others pin the number at higher rates. We know that individuals with money are trying to get the vaccine first, right? What does this do for trust, right? So there's this issue of trust. Do people have trust in the healthcare system, the public health system, in public systems per se? And what do we do in those situations when individuals with money are trying to jump the queue, as it were? Of course, it's not just happening within a country. We know this is happening between countries. So at the beginning of the pandemic, as is often the case, there's a lot of big talk about solidarity, about everyone in the world kind of being together and kind of coming together. But then when reality hits, it usually tends to be that the high income countries are better off. And we saw this with the very last graph that Dr. Clapman showed. This idea that, when we look at where the vaccine is being distributed or vaccines are being distributed, it's usually not in low and middle income countries. We see also, though not directly related to COVID-19, we see that the ill effects of right-wing populism globally, rise of fascism, globally, and its effects on populations globally as well when it comes to COVID-19, whether it be the United States or Brazil or the UK. So we see the not that racism ever went away, but we're seeing a redoubling of efforts. Obviously, many of us are aware of what occurred on January 6th in Washington, D.C. That was based on race, based on this right-wing ideology. It's not just the right wing, right? We see religious minorities also being put in positions of peril, generally speaking, and also with regards to COVID, when we look at the Uyghurs in China, right, and the forced labor camps, again, greater susceptibility in second and tertiary waves. So again, not just limited to a country or a certain set of countries. And even countries that are purportedly doing really well. So I'm originally from Canada, but I'm living here in Australia, and every time I chat with my family or friends back home, everyone says how well Australia is doing, how lucky you are. Yeah, there are good reasons and good things that Australia has done, but it also has done it on the backs of, immigrant populations. It's done it by closing the borders because it is an island and leaving 25 to 30,000 Australians stranded still, trying to get back into the country. And Prime Minister Morrison earlier this week, or at the end of last week, has said that we're actually going to be receiving fewer international travelers into Australia. Again, very controversial. So that's some of the context that then grounds some of these ethical issues that we see, right? And some of the ones that we've been talking a lot about, or have been talked about a lot in the last 10 or 11 months, things like vaccine allocation and distribution, again, alluded to earlier in the first two presentations. One that has gotten a lot of airtime probably a few months ago, this idea of ventilator and ICU beds, who gets them, who doesn't. Border restrictions, as I mentioned a moment ago, and the relations to the international health regulations, which is something that most countries signed up on and then quickly disregarded when things started happening in earnest in March. What does it mean to communicate uncertainty in a post-truth world, to use that jargon, right? What's a fact, right? How do we convince people that facts exist? Addressing stigma, discrimination, et cetera, et cetera. What I want to just briefly argue now, sort of just keeping track of time towards the end, is this idea of that I think a lot has to do with risk and risk imposition as an underlying concern for a lot of these ethical issues, and a lot of what we're concerned about when we think about the context in which COVID-19 is occurring. So risk is usually understood as a description of a hazard, right? A particular thing that can go bad, and the probability of that hazard. That's usually generally how it's understood. One of the things that we're dealing with when we're dealing with probability is obviously uncertainty. Again, the previous two speakers can speak about this much more cogently than I can. But there's a lot of uncertainty with regards to the vaccine, with regards to the disease, the actual COVID-19 or the SARS-CoV-2 virus as well. So all this requires that we balance the risk and benefits of proposed public health measures, right? So there's the risk associated to the actual virus, and then there's the risks that are associated with the implementation of public health measures. So the clearest example is issues around mental health and people being in isolation, especially individuals who are single, being in isolation, right? People who can't, who are living alone. So, we're telling people to stay home. The reason we're doing it is a very justified reason, not to spread the disease, but doing so then has this, correlative effect, which is you increase rates of mental illness, depression, anxiety, so on and so forth amongst your population, right? So the idea is that there's a risk. How do you balance that risk and benefit if you're a policymaker? And critically then is that these public health measures are done unto free persons without their consent, right? This isn't just the case in Western countries, but we see this globally. Everybody has a certain amount of freedom, regardless of your jurisdiction. Here, we're imposing something without people's consent. What justifies ethically this imposition of risk? So in the context of ethics, what we're interested in when it comes to risk and risk imposition, we're interested in the cause of the hazard. So if risk is a description of the hazard and the probability, we're interested in the cause of the hazard precisely because we're interested in this question of responsibility. So ethics is often interested in questions of responsibility. We're also interested in the just distribution of risk. Okay, so a lot of social justice or discussions of justice are interested in distributions of benefits and burdens. There's a lot more to say there. But certainly in this case, we're interested also in the just distribution of risk. It's not fair, as it were, that it's always the same group of people who are subject to the ill risks of X, right? In this case, COVID. So for example, we see this, this physician, white coats for Black lives. Again, it's Black lives who are being disproportionately burdened by COVID-19 in the context of the United States or the UK, for example. So as I mentioned at the beginning, my colleague Max Smith and I developed a heuristic. The purpose is for policymakers to use this rather than individuals for reasons I can get into in the questions if people are interested. But what are some of the sort of the necessary conditions or things that we need to think about when we're thinking about imposing risk on individuals who we otherwise would not impose? So we want to act in light of reasonably discoverable facts regarding a particular risk. There ought to be some benefits about that risk that can be shared with the person that is being subject to the risk, either directly or indirectly. Imposing of the risk should be justifiable to the person to whom is going to be subject to the risk and in greatest position of the risk because they're being subject to. We should try to minimize the potential harms associated with particular action X. And should harm occur because of carelessness or recklessness, then the person who is subject to the risk should be compensated in some capacity. So just a couple of notes. These are necessary but not sufficient conditions. So for example, we're not talking about any issues of procedural fairness or justice. And there's a lot of conceptual work that underpins this heuristic, but I won't talk about it here. I have two cases, but just for the sake of brevity, I'm just going to talk about one and then go to the end. So imagine that the action that you're thinking about is actually just regarding the vaccine schedules, vaccine dosing schedules, right? So you're thinking of delaying past 21 or 28 days, depending on whether you have the Pfizer or Moderna vaccine, in order to stretch it out. You know, what's the risk? Reducing the chance or amount, question mark, how much, of immunization. So I just, jotted down a few notes. So, what are some of the reasonably discoverable facts? What is it that we know? We know there isn't enough of the vaccine going around. We know that distribution is slow. What we don't know, though, is there's a lot of uncertainty about what it means to delay that second dose, right? In terms of the in terms of the benefits to the individual who just receives one dose and then a delayed second dose, well, you could argue that that you're doing this to protect the broader community, right? You're doing this to distribute more of the vaccine, so there is an indirect benefit to the individual. When we think about, why we might be able to justify deviating from the dosing schedules, it tends to be because we have an inability in many jurisdictions to administer the vaccine in an orderly manner, right? Is that a sufficient justification, right? Is failures of logistics a sufficient justification? What types of failures of logistics are permissible and not permissible? Does this speak to more generally poor public health implementation, right? Are we in these dire situations because we haven't implemented properly other public health measures? Will this increase distrust? Will it not, right? So these are some of the questions that we need to think about when we're trying to consider justifying such an action. What actions need to be taken to minimize the potential harms, right? Again, I turn to the audience to this question. I'm not a scientist, so others on this call would be much better positioned, but we need to think about how can we minimize chances of harm, and then again, what would compensation look like? I'll skip that and I'll just sort of conclude by saying that, again, when we think of policy and health policy, it is fundamentally normative. That is, that it's fundamentally about values and ethics. That the risks of SARS-CoV-2 and COVID-19, there's risk associated with the actual virus, but we're also talking about risk associated with the public health measures, including new vaccines. And then critically, we cannot divorce or analyze these ethical issues outside the context of politics and these social issues, right? What's happening in the world, in politics more generally, in society more generally, should be within the purview of things that we are interested in as healthcare workers and as scientists. So thank you very much. I'll just stop there.
Okay, great. Well, thank you very much, Diego. Wow, this is a very good talk and really touch a very basic value system and how ethics and value really plays an important role in the decision and also policy arena. And so we have much more to discuss at the end of this session. Just one note, and the report on the so-called forced labor and COVID-19 in Xinjiang, obviously disinformation is not correct. So this just want to make sure about that. Okay, our last speaker, last but not least, Professor Fujian Cui from Peking University School of Public Health. Professor Cui is Director of the Vaccine Research Center at Peking University School of Public Health. His research interests infectious disease, epidemiology and prevention, mainly focused on the vaccine preventable disease, and also the epidemiology research on the vaccine and the vaccination, immunization, intervention, international collaboration, and so on. And the title of his presentation is The Latest Development of COVID-19 Vaccine in China. So let's welcome Professor Cui.
Thank you, Professor Jane. Good morning, good afternoon, good evening, everybody. So my topic is the latest development of COVID-19 vaccine. So I will walk through the latest development and the vaccine are licensed or used globally. And everybody knows that the strategy to control communicable disease, there are 3 strategies. So if you manage the source of infection completely, I think you can control the pandemic, like tracing contact, isolating, quarantining. And if you interrupt the routine of transmission, like wearing mask, keep physical distance, and washing hands, you can also control the pandemic as well. But the issue is when we cannot manage the source of infection completely, and we cannot interrupt the routine of transmission, so there is a strategy protect the susceptible population, like vaccination, is one of the best strategy to control the pandemic. That's why people are relying on the vaccination issues to control this pandemic. And we know that vaccine is not only control the disease, but also, there are lots of the values, like the social and other benefits, like also protects unvaccinated population, and also prevention of the related disease and cancers, and extending our life expectancy, and also make sure travel is safe. So there are a lot of values. And as last week, we saw that globally, there are 289 vaccine candidates and 220 candidate vaccine in preclinical evaluation, and 69 candidate vaccine in clinical evaluation. And we see 5 licensed vaccine, either in emergency use license or emergency use authority. So these are generally landscape of COVID-19 vaccine. And if you look at the vaccine by the clinical phase and also by the platform, we can see there are almost, saving kind of platform used for developing of the COVID vaccine. And most used are protein subunit platform. So there are totally 89 vaccine are developing, but only 4 in phase 3 clinical trial. And the first, I think, the most, they're licensed and there is a RNA vaccine, which 3 already in phase 3. And we can also see that for the no replicating viral vector platform also has 35 vaccine has been developed and 4 in phase 3. And for the inactivated vaccine, there are 6 in phase 3 already. So if you look at the proportion, it seems that the protein subunit vaccine is most used, and inactivated vaccine is most successful in the clinical trial phase 3. And we don't know who will be in the end took the lead and have very good either efficacy or safety. But at this moment, we can see this is the update information so far. And if you see the vaccine has been in phase 3 clinical trial, either in the phase 3 clinical trial ongoing or either emergency license. So there are 3 platforms I show in red are most in the advanced stage. And the vaccine I show in green are already licensed or used globally. So this is the vaccines globally. There are 20. So 50 in phase 3 and 5 already been licensed. And if we look at the vaccine by the dosage and the timing, we can see most of the vaccine use the 2 dosage schedule, and 1 vaccine, China produced vaccine, which is based on the no replicating viral vectors, China Cancino Institution, which is only 1 dose. And also there is another protein subunit vaccine, which developed by the China Anhui Zhifei company, which is planned to use 3 dosage, 1 30 days and 60 days. So this is the schedules for the vaccine is being developed. And generally you can see most of the vaccine use 2 dosage schedule. And we know that there are some requirements for vaccine development. For example, the study shows that vaccine has to be an efficacy of at least 70% to prevent the epidemic, and of at least 8% to largely extinguish epidemic without any other measures. And the WHO have its another benchmark for COVID-19 vaccines. So the benchmark is 70% efficacy and a duration looking for a year, while the lower threshold call for 50% of the efficacy for half a year. So coronavirus developers have some advice also from FDA say to win the approval, any vaccine must be at least 50% more effective than placebo in preventing the disease. So this is a basic requirement for vaccine development. And let's see the safety issue for COVID-19 in phase 3. So we know that safety is a big concern for many people. So when the people receive the vaccine, the first concern is the safety. Is the vaccine safe? So if we look at the vaccine in phase 3, some data we collect from the either phase 2 result or phase 3 result, because not all the company reported the phase 3 clinical trial result. So if we see the local reaction, there are big difference. For example, mRNA vaccine produced by the US Moderna company, which shows more than 90% of the local reaction. And also the US Norway is showing 92% as well. But some vaccine only report like the 20 or 30 something local reaction. So people may ask, what caused such big difference? I think this is because they have different diagnostic criteria and also have some, their including criteria and the excluding criteria. That is different. And also because their vaccine itself has some difference. And if you see the adverse event which is greater than grade 3, so the lowest is like 0, the highest almost reach 15 to 16%. So this is, I think, the same reason causes the difference. But luckily, we see that no severe adverse event is observed in many of the vaccine. And most of the vaccine can cause only the pain, fever, something, which is very normal and very common. And if we look at the efficacy of the COVID vaccine, so the serocoverage almost reached 100% for all the vaccine. But the GMT antibody level, there is a big difference. So the highest as like more than 400, but the lowest only less than 20. So I think the issue also like there is no standard way to measure the antibody level. There is no standard way to compare which vaccine is more efficacy than another one. So this is the issue. Maybe we can, have the systematically evaluation to the vaccine efficacy, and that's a very good standard way. And there are some vaccine already in the license process, like the vaccine produced by Pfizer, Moderna, Oxford, Galamaya, and the Beijing Institute of the CNBG. So this is a vaccine which already approved for use either emergency or with conditional approval. So the adverse events, we saw almost no severe adverse events, and the study population is bigger enough to draw the conclusion. And we see that vaccine efficacy, which already have the 70 or 95%. And yesterday we heard that there is some argument about the vaccine efficacy, and people debate about the vaccine which might overestimate the vaccine effect. We don't know, but also people think probably we can look at how they including their patients or the infections and how they exclude infections during the clinical trial. So this is the issue really a key point to think about. And in generally, so based on the available information so far, we are happy to see these vaccine already show very good safety and efficacy. And I can go further about the high-risk population vaccination issues. So only the one vaccine the Pfizer company produced, they observed the efficacy among the hypertension and obesity population. So which shows the similar vaccine efficacy as the general population. And for the rabies vaccine, they don't have enough data to show the efficacy among high-risk population in phase 3 clinical trial. And the vaccine already being licensed in many countries so far. For example, Pfizer licensed in UK, in US, Moderna vaccine granted emergency use in US, and the University of Oxford vaccine approved for emergency use in UK and India. And Russia's vaccine is one approved vaccine approved very early, but they don't have their clinical phase 3 trial result. And the Chinese vaccine was produced by CNBG, approved in UAE, Bahrain, and China. And we saw some news are from the literature says already some other vaccines which not showing here are already used with also conditional approval. So this is a vaccine globally approved. And so in summary, we see the 6 platforms are used more common to develop the vaccine. Most use the 2-dose schedule and the intramuscular injection method. And the range for the 2-dose mainly from 14 days to 6 days. And most vaccine showing the result from the phase 2, saying the safe, well tolerated, and higher immunogenic. And some of them potentially has the particular humoral response against COVID-19. And neutralizing antibody response may be higher than outpatient. And this is we learned from the phase 3. And I can also show you the latest development of the COVID-19 in China. So China uses 6 parallel technical routines in develop their vaccine, and 16 vaccine in clinical trial, and 4 vaccine in phase 3 clinical trial, and 1 already have been licensed. So this is the latest development, and we can see China compare the vaccine can compare with the international company, and also have developed the vaccine very quickly. And a little information I can touch base is the homing challenge study, which is not shown by the company this time, because at the beginning when people think about how can we do the clinical trial when some kind of without any the pandemic, so they need to have some the alternative methods to accelerate the development of the vaccine, or can simulate the same clinical trial. So this kind of the method used since 1940s, and it already used for malaria, typhoid, cholera, norovirus, flu, and Zika. And we can see this already have the experience. And but only one country, UK, try to use this kind of the method to test the effects of the COVID-19. And we haven't received any latest data about this clinical trial, but we are expecting to collect the data and to look at how this kind of the clinical trial can help the company to develop the COVID-19. So there are many countries already studied the vaccination. So in China, we have the studied vaccination since last month, but we use a 2-step strategy. So step 1, mainly for the key population, including the population worked in import contain, port inspection and quarantine, the ship, aviation flight, the fish market, public transportation, medical, city staff with higher risk, as well as the risk countries or regions to work or to study. And we should know that the more vulnerable older group are not among the previous population for the first step, and all vaccines are for free. And when we vaccinate all this priority population, China will go to the step 2, to vaccine more people with approved vaccine with condition, or the gradually increase the vaccine production, more vaccine will be used, and the elated people will be get the vaccine gradually. So these were based on the vaccine production capacity, and also based on the pandemic curve. So this is some information we learned, but something we haven't know. For example, we know the requirement, but we don't know the efficacy among the adolescents, the children, and the pregnant women. And we don't know the efficacy among people with some kind of the disease, like the cardiovascular disease. And we don't know the safety among the adolescents, children, pregnant women, people with cardiovascular disease, and with some basic disease conditions. And we don't know the duration of the protection for the vaccine we have been developed. So these are issues we are need to continue to look at. So for next step, I think what we have to evaluate is that, generally we have to look at the trend of the pandemic. We have to look at the impact of the mutated virus on control strategies, because the mutated virus can bring some impact for the trend and also for the vaccine. But so far, we are maybe more optimistic about the vaccine, and we need to continue work on. And the effect of the variation of vaccine efficacy must be an issue and a key part to be taken care. And as other professors already mentioned, we have the vaccine, but the vaccine hesitate may be an issue to be a header for the vaccination. And we also need to look combined with other strategies, what is the impact of vaccination on this pandemic. So there are a lot of concerns, and we need to look forward, have many of the solutions. So my short message is the impact of the pandemic is beyond the health. We already learned. Everybody ever learned this lesson. And no country is safe until all countries are safe. So we have the vaccine, but maybe we should not be optimistic. Vaccine alone is not enough. At this stage, we still need other measures to be taken. And the vaccine safety is a concern, because either you have the vaccine showing very good safety result, but some people will not take the vaccine. So when the vaccine is available, not all people are willing to take the vaccine. And of course, the equity, affordability, accessibility is a concern. All are concerns. And the vaccine candidate absolute a concern as well. So these are issues we need to discuss, and we need more solutions. So thanks for your attention, and I think I stop here. Thank you.
Well, thank you very much, Professor Cui, for your insightful review of the development of vaccine right now. Well, I really want to thank for speakers for their wonderful presentation, which really covers a lot of information for us. So we'll move to next phase, which is a Q&A and a discussion. And we have over 200 participants in this webinar, and there are quite a few comments, questions to go through. So next I will just quickly go through some of those questions, ask our panelists to respond. Okay, so the first question from Charles Johnson say that is it permissible to conduct a human challenge trial or challenge human infection model, considering that pharmaceutical company has competitive data of safety and efficacy rate of their respective vaccine candidate. I'm sure that Professor has answered the question. Is there any additional comments from Dr. Clark or Dr. Cui about that human challenge trial?
Yeah, maybe I can add a little bit about this issue because, on this kind of strategies to accelerate the vaccine development, but it's not complete acceptable by the FDA. So in this, angle, if the FDA has some requirements which say they can accept the, the rejection or license for homing challenge study, that's okay. If FDA, doesn't accept, or they say you have to provide other clinical trial data as well. So that will bring some issues for such kind of the technologies. So this I would like to highlight. Over.
Okay, well, thank you, Dr. Cui. Any more info or anything to add, Dr. Clark? No.
No, excuse me. No, I don't have any. The ethical issues of human challenge trials are very complicated. I can't really get into that here.
Okay, great. Okay, all right. Next question from Professor Zhofeng Zhang of UCL to Hannah. Well, thank you very much for your wonderful talk. In the low incidence areas such as China, Taiwan, Japan, if there's an outbreak of COVID-19, do you think that vaccine could be effective way to control for outbreak among individuals who are COVID-19 test negative, the outbreak site and the nearby area, in addition to treatment of patient and isolation of close contact?
Thanks. Yeah, this is a great question. So I guess one way that this kind of thinking has been applied a little bit is if you start to see outbreaks in certain populations, then you can sort of think about that group as a risk group that you then would start to kind of vaccinate more widely in that risk group. So that's something that we've certainly seen. In terms of sort of outbreak control, in terms of which almost kind of a ring vaccination type strategy, which was what we did see for Ebola and other things, where you're trying to sort of chop off, take out the susceptibles that you think the infection is heading for. Initially, I think for COVID, people thought that COVID moved too quickly and the vaccination would kick in too slowly for that to kind of be a strategy. But we might see, as we saw in two of the presentations earlier, that actually in some of the vaccines we are starting to see impact kind of two weeks after, after that first vaccination even. And if some of the newer vaccines that are coming on are one dose vaccine, then I think that's certainly something that could be thought about more in terms of sort of targeting of those vaccines. But it would have to be something that would have to be fairly agile. I guess that's the other thing to kind of think about there, that getting the vaccines to the right place in the right time. So not to say it would certainly work, but I think we might be moving towards a place where we could be thinking about that more. But I don't know if any of the other panelists have thoughts on that.
Okay. Okay. The question from Shirley Lau and Kumar Saha. What is the protection period after Pfizer Moderna vaccination efficacy lasts? So how long the protection period lasts, Dr. Clark?
Excellent question. Nobody knows. We have data for 3 months. That's what's been reported so far. And it's believed that there will be protection for up to 1 year, but there's not yet 1 year of follow-up to show that.
Yeah. Question from Professor Zhofeng Zhang to Dr. Clark. If anything goes well, when would it be possible month for most of the US population with COVID-19 vaccine, June or July or August? Most population in the US, Canada, and the European country have had a vaccine in the next 6 to 8 months. But poor countries such as India and Mexico only have a lower proportion of population with vaccination. There would be a huge gap between high income and low income countries. What would be the major impact on the global pandemic control?
Yeah, so the projections are that most people in the US will have vaccinations by July, August, September. But then the second part of the question, I think, is much more important, which is what do we do in terms of the global community, in terms of making sure that everyone is vaccinated? Because even if you're looking at purely self-interested motives among people in the US, the risk of exposure are still there if people are traveling around the world and other parts of the world do not have access to the same vaccines that you do here, then it's an ineffective response. So I think that's why we're seeing that a lot of investments, and hopefully there will be more of a coordinated global response rather than this individual country response that we've been seeing so far, to get vaccines available to all parts of the world, even the places that don't have the budgets or the economies to sustain large purchases of these expensive vaccines. And I think that's also why it's so important that we're seeing these multiple different vaccine candidates that are being developed. As I said before, the mRNA vaccines have limits to their production capacity. We can't give this to everyone in the world. So there need to be other alternatives that we can use, other alternatives that don't have the same storage or shipping requirements as the mRNA vaccines that have been proven effective. So hopefully we'll have more information coming up with these other vaccine trials to find other candidates that are maybe not 95% effective, but pretty close, that can be used in other areas of the world, and so that we can make sure that everyone everywhere is vaccinated.
Great. Question from Professor Mann, PKU, to Dr. Clark and now panelists. How to increase trust of people to safety of vaccines? It seems that many people have concern about safety of the vaccine, and also the vaccine hesitancy is quite prevalent.
Yeah, and I'd like to hear from the other panelists as well, but all I can say is that that is a big question that we've been trying to deal with. Some of the people I work with here in the US have been trying to make public shows of getting the vaccine, show people that it is safe, that it's not a problem, they aren't having big side effects. We've been trying to work with people from communities that have a lot of historic levels of mistrust to get people from the same communities to get the vaccine and serve as models to others. But I'd like to hear from the other panelists as well, what they think.
Okay, yeah. Others to add? Yes. Dr.
I think this is a very good question, and so I agree with the Professor Clark, and I would like to highlight maybe, so to make sure that people to have some safety, concern, we have to make sure the information we are delivering is transparent way, and we also need to provide the evidence in the scientific-based, method. So these are two, I think, key issues we need to avoid the people's hesitancy, and this will be built certified and to make sure people can understand and accept their policy recommendation. Over.
Great.
I don't think it's just a matter of information deficit or scientific illiteracy. So there's work been done by several colleagues, including Maya Goldenberg, who's in the University of Guelph in Canada, looking at vaccine hesitancy. And one of the things that a lot of her colleagues have found has to do with the fact that you can't take vaccine hesitancy outside of the context of sort of the politics of trust more broadly in public institutions. So I think that we need to ask this question about what is it for individuals to trust public institutions? And a lot of that has to do with prior incidences that either build or take away trust. And so part of, not to sound defeatist, I think we need to have the information clearly. I think it's great that we have, working with community members from communities that we know are more hesitant certainly helps. But we need to stop thinking about these things like this vaccine hesitancy as these sort of siloed individual one-off things. They exist in a context, and I think the critical part is understanding the context of mistrust that happens of more public, of politicians, of the political system more generally. I think there a lot of the focus needs to be, and a lot of the building of the trust needs to occur.
Okay, well, thank you, Dr. Silva. Well, just one question for you from Professor Zhou Fengzhang, you've covered a very critical area of COVID-19 vaccination, which is very helpful. If a government or universal work company or requires all workers or students to have vaccine as a condition for the job or student status, do you think that this is ethical?
Well, again, I think it depends. Usually, when we're looking at private corporations, we think that they have the ability to sort of set forth certain parameters as private corporations, whether they kind of go in, who goes in, who works or not. It is the purview of organizations to protect the health of their workers. So I think that it's not completely unreasonable to have certain mandates from companies. I think it depends on what the company is and what it does. If it's a tech company, say that you can do a lot of work remotely, do you want to mandate vaccination? Probably not. But if it's a service sector where you're interacting with a lot of individuals, you might consider it. Still, there you have to consider issues of socioeconomic as well. Is it individuals again that have a mistrust of science for very good sort of historical reasons? It's not enough just to mandate vaccination, but if you do mandate vaccination as a private company or as a company in general, I think there needs to be a lot of support systems in there to get people to sort of come on board if you were to go down that path. The other last thing I'll say is that generally speaking, you want to make things mandatory as a last course of action, not as a first course. So what are other things that you can do to get people on board prior to getting to the point of actually having to mandate vaccine uptake?
Great. Well, thank you, Dr. Silva. A question from Xu Jing of PKU for Dr. Clark. I would have assumed that the US, giving its top global health security index ranking, would have a much better prepared plan for vaccination during the pandemic. Is there anything that you can reflect why this seemed not the case? Is there any lessons learned as to the public health system or anything that we can really, does it reflect that the federalist structure of the US public health? Is that too decentralized or something like that? Any thoughts about that?
Without getting too much into politics, I will say that I think we've had problems with leadership in the United States for the past several years, and this is just one big manifestation of it. I think there were existing plans to deal with an epidemic like this, which were ignored. So I think that's the main problem.
Okay. Okay. Next question from Davinder Singh. Would it be wrong to say that total democracy is the cause of difficulty in containing the COVID infection spread? This is also a political issue.
Yeah, I would say that's wrong. So the proof is that there's a lot of democratic countries that have done just fine. Mm-hmm. I think that, and there's a lot of countries that are not democracies that have done really well as well. So I don't think it has to do necessarily with how you structure representation or not of individuals within government. I think it has to do with other factors, including general issues like racism and whatnot.
Okay, good. Question from Andrew Chan. Based on current scientific evidence, does delaying the second dose of a COVID vaccine still provide the same efficacy? Since in both Pfizer and the Moderna clinical trial, they have a specific vaccination schedule. And also we heard that the U.S. administration, both the current and the incoming administration want to roll out the first dose as quickly as possible. So any comments on that, Dr. Clark?
I would say we just don't know. The clinical trials were set up in such a way that they made very specific dosing schedules and assessments, which is the way that you need to run a clinical trial. So variations from that, we just don't have evidence on. They may work, but we just don't know.
Mm-hmm. Okay, good. Okay, question from Professor Jack Needleman of UCLA. One of the big unknowns in established policies for vaccination and maintain restriction on social contact is whether those who are vaccinated can transmit infection. Can Professor Clapham, this is for Hannah, discuss what her modeling suggests about appropriate strategy for vaccination and post-vaccination public health restriction in the face of this uncertainty? And can Professor Silva discuss the ethical dimension of making appropriate policy in face of this unknown? Hannah?
Yeah, this is a really, really important question that we're seeing in a lot of the vaccine rollout. So the trials were designed generally to look at symptomatic outcomes. And so that's the information that we have. Some of the trials are now starting to do some things that give us some information about what the impact those vaccines have had on asymptomatic infection and infectivity. So those are the kind of things that generally, you know, we're keeping a very close eye on and trying to interpret as they come out. And I think, you know, we could get some real world evidence for this for places where vaccines have been started to be rolled out and in bigger populations. But this is one of the things that I was talking about, that it will be quite context specific. So we'll have to think very carefully about what we see epidemiologically in vaccinated populations and how we can interpret that in terms of the transmission blocking or the infectivity blocking. In terms of modeling, yeah, something that we're looking at very closely and a very hotly debated currently, and also sort of trying to really think about how we put the results out there. You know, we can say if a vaccine is infection blocking, it will do this in the population, that's great. But if we're in a situation where we don't know that, how do we nuance those results in a way that they're kind of useful and interpretable? And it'd be great to hear from Dr. Silva about the kind of ethical implications of that as well. So I think we can kind of think about those purely in a modeling. Yes, if the vaccine does this, it has this impact. You would then perhaps target different groups, you know, if you are looking at transmission blocking, but we have to be very careful in saying this is what we will know about the vaccine and kind of putting it in that context. So.
Okay, Diego?
Yeah, I think Dr. Clapham actually touched on a lot of the ethical issues as well. I think that in terms of dealing with the uncertainty, you want to be, others have mentioned this already, but you want to be very transparent with what you do know and what you don't know. You want to have a very strong pharmacovigilant post-market surveillance system set up so that you're trying to able to answer these questions. And again, just to echo what Dr. Clapham said more eloquently than I could, which is the idea of being able to distinguish what's context dependent and what can be universalized or generalized. So I think some of the very same things would apply from an ethics viewpoint as well.
Great, thank you. A question from Collins Chong. The risk for vaccine has laid bare the inequality and the division of societies and countries based on wealth, power, capability, and influence. New phenomenon of vaccine diplomacy and with the vaccine being used as a bargaining chip for other interests has been worried and putting a vulnerable group and the countries at the mercy of power wielding parties. What can be done and what is the way forward to address this? So panelists.
So these are diplomatic questions. So we have to deal with the diplomatic ways. So I think we are talking about the technical issues. So that kind of the question we really don't know to answer the audience. Sorry.
Well, certainly this is really a global health governance and international relation and all this. So really need some guidance from I don't know whether WHO and other body can really help guide this process. Anyone want to chime in? Clark?
I can just say briefly, yeah, very difficult question. And I think you're right, it does come down to governance and lots of other questions. I do think, however, as scientists, we do have a role to play in that process. And I think that it's very easy to say, oh, we're scientists, this isn't part of our thing. And we should, of course, talk to the experts and in various other areas. But I think it is something that we can all have some kind of like, some continued awareness of. So be my two cents on that.
I think so. Do you think that organizing like a APRU probably can play some role or some role in such governance issue?
The other thing on the governance question is that in addition to individuals working in international relations and global governance, these are an excellent questions for historians and for sociologists and anthropologists. So the social sciences more broadly, but we always forget of our colleagues in the history department. Historians would have a very interesting response to the question being posed, because I agree that it's a very difficult one.
Sure. Yep. Okay, great. Thank you. From Andrew Chen, how do we know if current FDA-approved vaccine are able to protect people from the mutated virus? Well, this is a new, more contagious variant. Are there any studies supporting the efficacy of the vaccine for the newly discovered variants? Dr. Clark?
So again, there are no studies looking at it because it's fairly new and they haven't had a chance to study them yet. It's reasonable to assume that the vaccines will still be effective against these mutations because most of the vaccines are targeting a very specific protein on the surface of the virus called the spike protein. And so long as the binding sites on that protein are not mutated, then there shouldn't be any problem.
Mm-hmm. Okay. Question from Czech body. I'm curious about emergency approval of a vaccine such as in India. Does that mean they have skipped some stages of a trial? What are the ethical implication of that? Diego?
So on the previous question of whether steps have been skipped, my understanding, but I'll turn to the other three panelists. My understanding is that no steps have been skipped. But in terms of the approval has been accelerated. In the context of India, I'm honestly not sure, but it's not uncommon to accelerate the approval on condition of more information as it becomes available. But again, I'm very hesitant to say much more on this in general and in India specifically.
Mm-hmm. Okay. Louisa Sun to Professor Cui, please elaborate how vaccine efficacy measured in population that has achieved a very good control of pandemic. I'm not sure whether this.
I think that, yeah, these are a very good question. So when we look at the efficacy for the vaccine, we need to know, I think there are three major indicators. One is the safety indicators. So to make sure vaccine is safe. The second indicator is to look at the efficacy. So when we look at the efficacy, we have to, observe this impact in the big enough population. Let's say this time, all the study population are more than 30,000. So this, to make sure we have the higher confidence to answer the efficacy issues. Either third indicator is the duration of the protection. So at this stage is all the vaccine have not collected the data for their the duration issues. So we have the indicator for safety, we have indicator for efficacy, but we don't have that indicator for the duration protection. So for the efficacy issue you are asking, I think that's based on the study population compare among the placebo group. So this is totally based on the experimental evidence, and I believe that can give us the confidence to say this vaccine have how higher the efficacy over.
Okay. Question from Professor Zhang Zhofeng of UCLA to Dr. Cui. China has developed many different types of vaccine. Do you know if any type of vaccine developed in China covers aging population, young population, or other population? If both age groups are not covered, how would China achieve herd immunity of 60 to 70% in order to control COVID-19 effectively?
This is an excellent question. So this is also a very key issue, and this is the homework that FDA required the company to do. And they need to have to include in the more elder people, the children, the pregnant women, and also some, people with, disease condition. And if we don't have such kind of evidence, we cannot say this vaccine will be safe and effective among such kind of the population. So this is one of the issues. FDA have to monitor, and also the company have to answer this question. I think we would, we are expecting in the coming months, the company need to have the solution. Over.
Okay. Just one last question to the panelists. Can you also comment on the rules for COVAX? Were COVAX sufficient for addressing global distribution of COVID-19 vaccination, solve the inequality issue, particularly in the low or middle income countries?
Yeah, so I had very high hopes for COVAX, and I think it's an excellent initiative. We did see some news sort of fairly recently that there were concerns about funding and the kind of timing of what would be possible with COVAX. So I think it's a great initiative, and I really look forward to seeing what it does. But it seems like there does need to be kind of continued, renewed sort of international efforts. I think what perhaps we should have foreseen, and maybe some people did, but is more of this kind of unilateral countries. So countries that have bought kind of too much of the vaccine for themselves and then deciding what to do with that. So I think sort of those two, COVAX and that strategy, will have to sort of be monitored very carefully as things progress on both fronts.
Great, well, thank you. I was reminded that our time's up, and this is a really very quick, very a short 2 hours that we've go through, covers lots of topics. And I really want to thank all speakers and the panelists for your insightful presentations and discussions, and I thank all participants for a very engaging sessions of discussion. Unfortunately, we just could not do that in a longer time. So, of course, as I mentioned earlier, that there will be another webinar scheduled in March and sponsored by the University of Sydney. So stay tuned for the future announcement. And for that, I really thank again to our panelists and participants for participating in this webinar. And stay fit and keep healthy. And I will see you in March. And thank you very much. So that concludes this webinar session. Thank you.
Thank you. Goodbye.
Goodbye.